Okay, well, welcome to you all this evening. Simon Smail is going to give us the talk tonight, and his topic is epidemics, public health, and COVID. I think most people know Simon, but Professor Simon Smail, CBE, is a long-time RADA resident and has held many positions in the medical field, including being Vice Chair of Public Health Wales NHS Trust. He has retired, but he's still an Emeritus Professor at Cardiff University. He's a Fellow of the Royal College of Physicians, a Fellow of the Royal College of General Practitioners, Fellow of the Royal Society of Public Health, and a Fellow of the Higher Education Academy. Some of you might also know him as he was the radio doctor for BBC Wales for 15 years. I'm afraid that's something I don't remember at all, but there we are. And hopefully this talk will fit in very nicely with the talk we had, I think, about 2 to 3 months ago from Ron Eccles. So I'd like to pass you over to Simon.
Right, can you see my screen now? The title page, Epidemics?
Not yet, Simon.
Not yet, no. Well, that's strange.
We'll give the share screen another try. It should push through.
Can you hear me now?
Yes.
Right.
We can't see your screen though. Ah, yes, you have now.
You can see it now. Can you see?
Yes.
You have a picture. Right. Can you see the main screen now? The title page.
Yes.
You can. Brilliant.
Yes.
Brilliant. I'll just put this into full screen. There we are. Okay. So can you now hear me? Can you see the title screen? Epidemics, pandemics, public health, and COVID. Yeah.
Yes, we can see it and hear you.
Right. Excellent. Well, sorry about that glitch. First of all, David has made the point that I have retired from all of my various appointments in public health. And so anything that's happened in the last 3 or 4 years is something that has happened in public health that is not within my control or influence in any way whatsoever. So that's just a sort of declaration of intent. Now, the title I have taken is Epidemics, Public Health and COVID. And just a few definitions to start with. You probably know that the word pandemic comes from the Greek. Pan means all, and demic is a derivation of demos, which means the people. So a pandemic is something that affects all the people, an outbreak that becomes very widespread and affecting the whole region, a continent, or the world. An epidemic, epi in Greek means on, so an epidemic is on the people, and that is an outbreak affecting more than the expected number of cases in a community. Something that's endemic is something that's within the people all the time. So you could say the common cold is endemic. But the pandemic and epidemic are the cases that we're going to consider now. Now, the first of the various plagues that have beset the world over many, many years is the bubonic plague. This is a bacterial disease, and it's probably been the major cause of death in epidemics and pandemics over the centuries. Indeed, the causal organism is a bacteria, which was only discovered in the last couple of centuries. But we know that bubonic plague was known at the time of Homer, because in the Odyssey, written roughly in the 2nd century BC, he refers to Scylla and Charybdis, who were the mythical creatures who lived in the Straits of Messina on either side of the straits. And he described Scylla, which is a multi-headed beast, top right corner, with her mouths full of black death. Now that will strike fear into anybody who knows about Black Death, because this is one of the worst epidemics that has ever, the continuing recurrent epidemics and pandemics has ever affected the world. The disease actually is endemic amongst rats. Rats have it more or less all the time. And even nowadays, there's odd outbreaks of plague that are generated by rats. So the disease is spread from rats to humans by fleas. And on the bottom right, you'll see a picture of a flea that has taken a nice little meal of blood from something or other, either from a person or perhaps from a rat. So the fleas lived on the rats, and they suck the blood from the rats, and then they transmit it to people. Now, the Black Death is well known as a major epidemic in the 14th century. And the Black Death caused fever, joint pains, buboes, which were swellings around lymph glands, which often kind of went necrotic and went black, so hence Black Death. Started in Central Asia, spread throughout the world really, through rats living in ships, and then throughout Europe. It is estimated to have killed more than 30% of Europe's population, but the total deaths were around 75 million. Extraordinary figures. The Great Plague of London was another recurrence a little bit later than the initial epidemic or pandemic of the Black Death. And it raged in the 17th century over about 18 months, and a quarter of London's population died, over 100,000 deaths. So, you know, COVID is nothing new in terms of mass deaths. The next big epidemic that one should take note of, and this is quite an important epidemic, is the cholera epidemic in London, 1854. There was a worldwide cholera epidemic from 1846 to 1860, which started in Russia and killed over 1 million people. But then there was a local outbreak in London around Broad Street, 1854. There was no sewage system there, and several thousand people were infected, around 600 deaths. And people didn't really know what the cause of this was. They thought it was something in the air, miasma, some invisible particles in the air. But this particular epidemic has become quite famous in medical history because there was a doctor who was working in London at the time, Dr. John Snow, who had an inkling that it was something that was being transmitted from house to house in some way. And he drew up a map, and on the left-hand side of the screen, you'll see a map with some big labels on it, but you'll also see lots of little black squares. And the little black squares each represented a case of cholera. And he realized that the cases clustered around Broad Street in London, not far from Great Marlborough Street. And in the middle of Broad Street was the pump that everybody got their water from. And he rationalized that the epidemic was being spread probably by the water from the pump. So what did he do? He took the handle off the pump so that nobody could have water from the pump. And lo and behold, the epidemic stopped. So he was able to prove that this was as a result of the water being infected. Now, John Snow was actually a very intelligent and well-known man. He even was the physician to the Queen, and during one of her deliveries, he anesthetized the Queen Victoria, with chloroform. So this was quite an event that again goes down in the history of anesthesia, but I'm not here to talk about that. So John Snow was very skeptical of the miasma theory of disease, and he said that the cholera must have some way of reproducing its own kind, must necessarily have some kind of structure, most likely that of a cell. And both John Snow, Louis Pasteur, and Robert Koch, over the next few years, came to the conclusion that the diseases, many of the diseases that were being experienced at the time, were actually the result of germs. Pasteur demonstrated that people could become infected by fluids containing these germs. He could sterilize the fluids by heating it, hence pasteurization. And once the theory of germ transmission of disease was accepted, prevention of disease by distancing patients with transmissible diseases became well established by the 1880s, which was just as well, because subsequently there's quite a large number of epidemics, which I'll come on to in a moment. Now we come to the Spanish flu epidemic of 1918. The Spanish flu epidemic was really serious. It was estimated to have killed between 50 and 100 million people. And it possibly began in southwest France at the end of the First World War. Although there were cases reported in the USA, there was cases in China. It was called, however, the Spanish flu because it was widespread in Spain and also attracted a certain amount of notoriety because it affected the King of Spain, who became ill with it. Most of the serious illness was indeed in young men. And you all know by now about reproduction numbers, the R number, which is the number of people one particular case can infect. And the reproduction number was around 2, which is a lot higher than is happening with COVID at the moment. Around 500 million people affected worldwide, probably a third of the world's population, estimated between 50 and 100 million deaths. Now, this is a very interesting slide here. This is a notice posted in Kingston, Ontario, where there was a lot of people coming in to Canada from the conflicts in at the end of the First World War. And this notice, if you can read it, the print may be a little bit small on if your screen's a bit small, but it says, theatres and moving picture houses shall remain closed. Churches and chapels will be closed and remain closed on Sundays. All schools, public or private, including Sunday schools, shall close and remain closed. Hospitals shall be closed to visitors. No public admitted to courts except those essential to the prosecution of cases. The board advises the public most strongly not to crowd into streetcars and to avoid as much as possible any crowded train or an assembly of any kind. Well, we've heard it all before, haven't we? What we're being told now. So they picked up on John Snow's theories of how diseases are transmitted. The chief medical officer at Kingston, Ontario was well versed in ways of stopping epidemics. So what we are doing now with COVID was practiced at the end of the Spanish flu epidemic. There was also another resonance here, which I have discovered. That's the top of the picture is a picture of a Spanish flu ward in America. In San Francisco being known for liberal West Coast thinking, there was a spike in Spanish flu cases, and everybody was told to wear face masks. But what happened? There was an anti-mask league. This was started by an attorney who thought it was an imposition on the good people of the West Coast of America to have to wear these silly things. And the first meeting of the anti-mask league drew a couple of thousand people, passing a resolution stating that mandated masks were contrary to the desires of the majority of the people. So there we are again. The anti-mask feeling is nothing new, unfortunately. So this is a sobering slide. Flu outbreaks worldwide. The worldwide deaths are huge, but the Spanish flu epidemic was the very worst. It's not really known how many people died during the Spanish flu epidemic, but between 50 and 100 million. You will also see that the Hong Kong flu, which many of us will remember, mortality rate was about 0.1%, 1 in 1,000. And 2009 flu epidemic, much lower mortality rate, only a tenth of what happened before. Annual seasonal flu, around 250,000 to 500,000 worldwide. Again, quite low mortality rates, but the earlier epidemics of Asian flu and particularly Spanish flu were really serious. The next epidemic that many of us will remember, and certainly I remember this taking place, was polio. There was an epidemic between 47 and the 1950s. There'd been a much earlier outbreak in the USA in 1916, but in England and Wales, there were at least 20,000 known cases, but 70% of individuals affected showed few or no symptoms. I certainly remember as a kid having a playmate who was walking around in a leg iron because he'd had polio. My elder brother was thought to have had polio very mildly, although he never got any paralysis. But he had a sort of flu-like illness, and our doctor at the time thought that this was polio. There was, of course, shortly after the outbreak in the late 1940s, early 1950s, there was a vaccine produced, the Salk vaccine, and that had to be given by injection, and then subsequently the Sabin vaccine. And I very clearly remember being marched off to the doctor as soon as the Salk vaccine arrived to get my jab for prevention of polio. But this picture of all these children, these are all children in these iron lungs. They had paralysis of respiratory muscles. So the iron lungs, I'm sure you all know how they work. A suction is generated by bellows under each of the machines, and there's a little motor that keeps the bellows going, and it sucks air into the lungs of the kids who are in the iron lungs. But I think that's a really extraordinary photograph. The next epidemic that we probably know now more about than we did at the time when it was first recognized is the HIV/AIDS pandemic. This was first recognized in 1981, and probably it was transferred from primates, spread through unprotected sex, blood transfusions, and hypodermic needles being shared between people. If people get HIV, it is a lifelong infection, but nowadays antiretroviral drugs can actually prolong the lifespan of people with HIV and AIDS to an almost normal length of survival. But of course, there are even more recent epidemics that are occurring. Ebola, highly infectious, and many of you will have read about these outbreaks that have happened particularly in Africa. Some of the staff from Public Health Wales have been out to West Africa to help with these outbreaks, spread by bats, but there is now a vaccine. And then we come to something much closer to COVID. And this is the severe acute respiratory syndrome, SARS-CoV-1. Symptoms actually are very similar to the symptoms of the current COVID-19 epidemic. And it is undoubtedly spread by bats, horseshoe bats. It's not as infectious as SARS-CoV-2, which is the virus which causes COVID-19. And just to get the terminology right, SARS-CoV-2 is actually the name given to the virus, but the disease is known as COVID-19. And that came about because somebody in some organization, I don't quite know which, decided to call it after coronavirus disease 19. And that 19 is because the first definition of the disease was in 2019. So that's how it has come to be called COVID-19. We also, of course, have silent epidemics, non-communicable disease, coronary heart disease, high blood pressure, obesity, smoking, and neurotic disorders, etc., plus a number of other non-communicable diseases. And the silent epidemics are, of course, things that worry doctors endlessly and very much to do with lifestyle. So we come on now to talk about public health services. So what are public health services? What does public health set out to do? Well, there are basically two separate strands to public health work. Health improvement, which is work to improve health and well-being, looking at underlying determinants of health, educational opportunities, and working with people to provide support to get more positive health outcomes for population, especially in those in greatest need. And it's very much about behavior. Health protection is much more about protection of individuals, groups, and populations through advice and collaboration. So health improvement is involving self-care, appropriate health behavior, healthy diet, exercise, immunization, screening programs, etc. Very much behavioral. Health protection, communicable disease surveillance, epidemic control, food and food premises inspection and hygiene, safe water supplies, air quality, and so on. And I first got interested in public health issues quite a long time ago when I was a relatively newly qualified GP working in Oxford, which is where I was originally trained. And I was a doctor in a GP practice right in the middle of Oxford, looking after academics, quite senior people who had been my teachers when I was an undergraduate in Oxford. And I was really struck by the fact that some seriously important people, seriously bright people would come into my surgery with not a clue about how to deal with basic, simple health conditions. And I'll never forget on one occasion, a young Don of my own college came into the surgery with his wife and his young child who had a cold. And they just did not know what to do. The child was a bit feverish. They hadn't got a clue about basic self-care. And that was something that really struck me. And of course, many of the Dons in Oxford colleges were not conducting themselves in the most healthful way of life. So the whole concept of people not being able to take care of themselves really struck me quite a lot in those days. I had a good friend who was a chap called Muir Gray, now Sir Muir Gray, who was a young published health physician in those days. And he and I chatted about all of these things. And we decided to collaborate with a publisher and rewrite an American self-care guide to medical care called Take Care of Yourself. So the book is full of algorithms and simple strategies for people to look after themselves if they're poorly. And that got published, and it was actually published just when I transferred from Oxford to Cardiff, and I got asked to do a radio interview about the book. And lots of people rang in about the things that we were talking about, and that sort of set me on a bit of a trail of medical journalism, not only radio but some television work as well. And I also was involved in doing a certain amount of journalism, and there's a picture there of a big sort of encyclopedia on self-care that I wrote in those days. But then at that particular time, I was a member of the Health Education Council, which was a UK-wide organisation, and they were looking to do something in the way of helping people to reduce risks for coronary heart disease, which in those days, we're talking 1970s, 1980s now, was a very serious issue. And so we managed to get a grant for setting up a demonstration project, basically, for health promotion in Wales before devolution. And that was called, that project was called Heartbeat Wales. Some of you may remember that. And subsequently, that was incorporated into an organisation called the Welsh Health Promotion Authority, which was set up to provide health improvement programmes, and it incorporated both Heartbeat Wales and a little bit later, the Welsh AIDS campaign, when AIDS became a big problem. And I'm sure you remember these leaflets. Don't die of ignorance, a very serious sort of stark warning to people to be careful about the use of needles and safe sex and all the rest of it. In fact, it was a very difficult time when HIV first came to everybody's notice. And how did we actually manage to influence people's behaviour? In fact, the Welsh office sent me off to San Francisco to find out what they were up to at the time, because in San Francisco, they had got far more experience of dealing with particularly the gay community. And we picked up quite a lot of tips from them in order to take this programme forward. So what kind of staff work in public health? Well, there's different types of staff on health improvement and health protection. Health improvement involves doctors, nurses, and the sort of behaviourists, psychologists, sociologists, educationalists. Health protection is much more sort of statistical, laboratory-based. We have epidemiologists, economists, environmental health officers. And in fact, the two sides of public health are very complementary. But one of the interesting things about having been involved in public health over the years is that you will find a lot of different opinions within public health. And when people describe themselves as public health practitioners, that doesn't really tell you where they're coming from, as it were, because some of them will be very, very oriented towards the sociological models. Others will be very oriented towards sort of statistics and epidemiology and that sort of thing. So it's a very mixed community, really. And certainly, I think this has been one of the problems that we've had with COVID, that a lot of the advice that's coming up to government is coming from lots of different places. And if you ask a bunch of people who all come from all these different places what they would do to do something in terms of helping with epidemics like COVID, they'll all give you different spiel. They won't easily work together. So the people dealing with COVID are not only the behavioural staff who are dealing with things like trying to make people understand about social distancing, but they're also having to draw up rules, regulations, planning vaccine rollout, and of course there's all the epidemiologists and statisticians. Now in Wales, we have Public Health Wales, which has been in existence for about 14 years. It's an organisation that covers all of the health improvement services, microbiology, health protection services, screening, quality improvement for the NHS. And it's a now quite well sorted organization. Having been set up 13 or 14 years ago, it's very well supported now by the NHS, has some extremely bright people working with it. It has a link with the World Health Organization, and some of the work that it does is accredited by the WHO, who of course are interested always in coming to steal good ideas where they can find them. And so it has a way of providing advice to the minister in a coherent way. And that again, I think, is quite important. So the chairman and the chief executive of Public Health Wales have a monthly meeting with the health minister, and that goes on routinely throughout the year, not just when there's emergencies. And the chairman and the chief executive take the views of all the various people who are sitting around the table and filter it through to the people in Cardiff Bay in a coherent way. Now, that's not what's happening in England, and that's one of the problems that we are facing, because Public Health England has been in a very funny place over the last few years. It was set up in 2013 when strategic health authorities in England were abolished. Public Health England took over the roles of a number of agencies, but most of the staff were laboratory-based people. They had relatively few people looking at the behavioural side of public health. And local authorities were then told to look after certain areas of public health, including local community and public health services and things like sexual health services and so on. Over the years between 2013 and 2020, the government stripped more and more money out of public health because they didn't really think that it was needed. And the Regis Professor of Medicine in Oxford, who has got involved quite heavily with the vaccine development, has clearly stated that one of the biggest problems in England has been asset stripping of the public health service in England, so that when it came to the COVID problem, there was not a coherent voice coming from Public Health England to the government. The government rushed around to get all these advisors into the government centrally and made some extraordinary decisions, which we'll come to in a minute. So Public Health England has not covered itself with glory. So what's going to happen? They're going to abolish it and start another body, which is going to be formed out of the remains of the NHS test and trace system, which is currently funded at £22 billion. And it's going to incorporate the current activities of Public Health England, whose current annual budget is £4 billion. So they're going to have a completely different kind of organisation, and it remains to be seen how that's going to work. So with COVID, what has gone well and what has not gone well? Well, I think the first thing that we have to say is that the rapid identification of the genetic structure of the virus was a real bonus. It was only within days of the virus becoming known in the public domain that people knew every single gene in the virus, every single molecule had been put in place, and people knew exactly what it was. That wasn't perhaps quite as surprising as you might think, because coronaviruses have been around in one form or another for quite some time. So the rapid identification was probably fairly straightforward. And then the vaccine development happened again amazingly quickly. I know a little bit about the people in Oxford who have been working on vaccines over the years. And in particular, they've been working very hard on trying to get a vaccine for malaria. And they have a very, very good genetics section. They can analyze the genome of almost anything in hours. And so the development of the vaccine was able to be taken forward fairly quickly. The collection of epidemiological data worldwide, I think, has worked pretty well, and the WHO has been very good on that. What has also been really interesting, and I'll come back to this in a minute, is that some countries have really done incredibly well in keeping the total number of cases down and the deaths down. So South Korea, for example, introduced strict isolation measures. Mongolia, today's data, 1,800 cases and 2 deaths, 3.2 million population, roughly the same population as Wales. New Zealand, 25 deaths and 2,300 total cases, and their population is 4.8 million. The few other things that have gone well, the early instigation of drug trials for those admitted to hospital. Oxford University Group have a very good track record in running drug trials, and the experts there, as soon as people realized what was going on, they pounced on the hospitals around the UK with protocols for drug trials, which basically had been sitting on a shelf ready to go, and they immediately set up randomized, double-blind controlled trials of drugs, including particularly dexamethasone, which is a steroid drug, anti-inflammatory drug, which turned out to be really helpful. And the results of that double-blind controlled trial was available within weeks of the coronavirus epidemic starting. In fact, interestingly, one of the guys who is running the dexamethasone and these drug trials was somebody who I used to work with in the Department of General Practice in Cardiff, and he left Cardiff to become a professor in Oxford, a chap I know quite well. And this was an absolute first. Nobody had done anything like this before. And then early adoption of effective treatments flowed from the fact that the drug trials were done so quickly in a very rigorous way. There also have been drug trials instigated for patients presenting to general practice, because it is very difficult to run drug trials in general practice in the same way that you can in a hospital. But nevertheless, again, the Oxford group have a panel of general practitioners who are well versed in the technology of double-blind control. The bit of good news is that people have discovered that taking vitamin D over and above what you're eating in the food is undoubtedly a good idea, especially in winter. And the normal required dose is about 5 micrograms a day. Anybody really who thinks it's worth doing should be advised to take vitamin D 10 micrograms a day through the winter, because you probably know that in normal course of events, you get most vitamin D from the sunshine in the summer, and in the winter, the amount of vitamin D we get from food is probably only just enough. And vitamin D undoubtedly helps the function of your immune system. So that has gone well. What has not gone so well is the early lack of appreciation in the community as a whole of the risk of asymptomatic infection. Around 30 to 50% of all cases are asymptomatic. And I remember last year in about March, I was reading a paper in the BMJ about a small study that had been done in northern Italy. Somebody, an epidemiologist, tested every single person in a village in north of Italy, and found that 50% of the people who had COVID didn't have any symptoms. And even then, people didn't wake up to the importance of this. One of the important things here is that it's people who are about to go down with COVID-19 symptoms are very infectious for 2 or 3 days before they get any symptoms at all. And then there are individuals who carry the infection and remain completely asymptomatic, but nevertheless, they can be infectious to others, although they're probably not as infectious as the people who are about to go down with COVID. There's been a poor and patchy response to social distancing requirements. And of course, we all know about the terrible things that have gone on with the procurement of PPE, billions of pounds spent on unsuitable PPE. And even now, doctors and nurses working at the front door of hospitals where they're admitting people with COVID are still not getting the right kind of PPE at the front door of hospitals. Those in intensive care are getting the right kind of PPE, but there are COVID patients coming to the accident and emergency centres, and still they're not getting the right kind of PPE. Physical and psychological drain on healthcare staff, of course, is something that has been in the press and is of really considerable concern. PTSD and long COVID affecting healthcare staff. Test, track and trace, it hasn't worked well. And as you know, £22 billion has been invested to run it, as I referred to earlier. Management consultants were recruited to run it from a central base using the telephone. But the real problem has been that there was poor advice being given from the English public health system about how to run test, track and trace. And history tells us that such efforts really should be locally managed and locally organised. Getting people who know the locality, who know the community, it is undoubtedly the best way of taking forward this kind of programme. The other thing that has not gone particularly well was the lack of testing of staff in care homes. And I'm going to get slightly technical now, because this is, I think, something that's really important, which has not been well understood, particularly by government. The most accurate test for COVID is a thing called the PCR test, polymerase chain reaction, which is a method that what happens in a sort of test tube environment is that the genetic material that may be in the sample is amplified by a complicated system, but it is very, very accurate and very few false negatives. Then the government heard about this newish kind of test called the lateral flow test. And the idea here was that everybody who was at the slightest risk could use the lateral flow test, do it at home, and would give them an answer in 20 minutes. And this would be a great way of making sure that people who were infected were kept away from spreading the infection. Now, forgive me if I, again, get slightly technical here, but we're in here with a bit of maths. And I think I need to explain to you why the lateral flow test is so appalling. The government should never have contracted to buy all these tests, it seems to me, although perhaps there may be some way in which it can effectively be used. But the problem with it is that if lay people use the test, which is what is expected to be done, the sensitivity is 58%. So that is the percentage of true positives that are identified. So 42% of people who have got the virus will not be identified. They'll be told they're negative. The specificity is about whether or not the test actually can make sure that there's no false positives. But the specificity is 99.6%, and 0.4% of the population being tested will come up with a false positive. So to give an example, in a population of 10,000 people with a current infection rate of 0.5%, which is about what has been happening in some parts of Wales over the last few months, 50 people will be infected with COVID. But if you do the lateral flow test on these 10,000 people, what happens is that you will find 29 people who have the infection will come up as positive on the lateral flow test, and 21 people who also have the infection will be missed. They'll come up with a negative test. So that's nearly half the people infected will be told that they don't have the infection. There will be false positives, 40 people. So the total results showing through doing the lateral flow test is 69 people. So just to summarize that, 29 people who really have COVID will be told they're infected. That's fine. They'll go off and become isolated. 21 people who really have COVID will be told they're negative and they can go off and enjoy themselves. Well, sort of. And 40 people without COVID will be locked up and told that they should isolate for 10 days. So is that a good test? Well, you can decide for yourself. But the reality is that the people who have a negative test should be told that there is still a possibility they might have the virus. So everybody else, everybody who turns up negative, really have to be told they still might have the virus. So it is really a very poor test. And yet the government have got all of these tests lying around the place, and they're handing them out to doctors in hospitals, to people working in immunization clinics, etc., etc. So this is still a bit of a problem. And in fact, last Saturday's British Medical Journal had a leading article about this. And as my previous slide suggested, the government are going to face a judicial review over the decision to purchase these tests. Now, the national strategies for controlling COVID, you will realize, have been different in different countries. And this is a little way of thinking about this. If you look at the central boxes on this slide, implementing the strategy can be done in different ways. And I've got a friend and colleague who works in southern Australia, a little way outside Melbourne. And in fact, he was doing a very similar job to mine, but in the medical school in Melbourne. And I've been in contact with him on and off through the pandemic. And every now and again, he sends me an alarmed email saying, "Simon, what really is happening with you? It's just dreadful. We're fine down here. We're all doing very well." Although that didn't happen completely in the area of Australia that he lives in. But basically, they have done a very, very good job of restricting spread of the virus. So the elimination strategy has been used in places like Australia, particularly New Zealand. New Zealand has done an extraordinarily good job. And I heard only within the last day or two that Perth in Western Australia was just behaving perfectly normally until quite recently, when they had one new case. So the whole of Perth has been put into lockdown because they had one new case. And that's the kind of approach that they have really wanted to persist with. And that is about eliminating the disease as completely as they can. And then there's a variety of other strategies that can be used: suppression, mitigation, and then no substantive strategy, which is the Donald Trump approach, of course. Now, this is another interesting slide, because there's been some discussion about what happened in the early spring of last year. So where did COVID come from into the UK? And you will see on this graph, this is graph for last year, February the 2nd, the 16th, March the 1st, etc. down here. And you'll see that there's one or two green spots, which are Italy. These are Italian cases coming into the UK. And before long, Spain was the next place where cases were imported. And then this huge spike when people were traveling around Europe and bringing it back particularly from Spain. So we got most of our cases from Spain, but also the blue area here is France. So we got quite a lot of cases from France. Now, a lot of news about the new variants. There's two new variants. Well, there's three new variants that are major concern, but there's two new variants circulating in the UK, and news about this today. The Kent variant is undoubtedly more infectious than previous variants, and it's a genetic mutation of the virus. The virus is going to be mutating all the time, and there will be a need to change the vaccine slightly as time goes by to make sure that it does deal with the variants. But the Kent variant, as it is sometimes called, or the UK variant, spreads more rapidly. And because it spreads more rapidly, the total damage to the population is going to be more deadly, simply because it spreads more rapidly. And so more people get infected than would have got infected with the ordinary virus or with the previous variant. But nevertheless, there does seem to be some evidence that the mortality will probably be about 10% higher than earlier strains. The South African variant, which is causing problems, and lots about that in the news today, is spreading, and it is again likely to be more infectious, just like the Kent variant. But its variant is as a result of a different genetic mutation. And then the P1 variant is spreading in Brazil and has caused a horrendous situation in Manaus, which is a town right in the middle of Brazil, which June and I have visited on one occasion. A very thriving town, big town. 75% of the population already have antibodies to the variant. And more variants are going to rise. That's inevitable. And just like with flu, the COVID vaccine is going to have to be modified as time goes by, because the COVID is going to be with us for years. There's no doubt about that. So the vaccines, I don't really need to go into this in any great detail, because I'm sure you've read all about the vaccines that are coming on stream. But just to say that the AstraZeneca Oxford vaccine uses an inactivated virus, which carries the genetic code into the body, and that then generates antibodies. And the government have ordered 40 million doses in the UK. The Pfizer vaccine is using a rather different type of technology. It just uses a bit of the virus, and it's carried into the body to make antibodies to that bit of the virus. So it primes the body to mount an antibody response. And the Moderna vaccine is similar to the Pfizer vaccine. That's been approved, but it's not coming on stream until the summer. There's another set of, there's another group of vaccines of which our government has put in an order. So we've got the Novavax. The government have ordered 60 million doses, another one called Valneva, and another 60 million doses, and Sanofi, another 60 million doses. And amazingly, worldwide, there are 79 vaccines in preclinical trials already, and another 163 in preclinical development. That is just extraordinary. Now, what we need, of course, is good vaccine distribution. This is a lovely photo that was in last week's BMJ. And this is Salisbury Cathedral, where you can go and get your vaccine shot to the tune of lovely organ music to calm you down. So we're just waiting for Rada Church to convert itself into a situation like this. And we'll have to get Lee to play the organ whilst we all go in to get our vaccines, perhaps, we'll see. So this again is an important slide, because this is the number of, this shows the number of vaccinations required in an age group to prevent one death. So if you are looking at residents in a care home, of whom there are 500,000, you only need to vaccinate 20 people in order to reduce the death rate by 1. For everybody aged over 80, you need to vaccinate 160 people to prevent 1 death. And so it goes on down this table. For the 70 to 75, you need to vaccinate 600 people to prevent 1 death for somebody aged 70 to 75. And if you go right down to the bottom, age 50 to 55, 8,000 vaccinations need to be given to prevent 1 death. And that's the evidence from the COVID-19 actuaries group. How soon will we see the effects of the vaccination? Well, if you look up here on the chart, we're here today. This is today's date on this chart. This is the 1st of January, and here we have the 9th of April. And we have already, it seems, begun to see a drop in hospital admissions, which is the red line. The yellow line is hospital deaths. And the actuaries are predicting, provided the number of vaccines given continue as they are at the moment, which is more or less on track, that within about a month, the hospital deaths will quite dramatically reduce. And we already have been told that there is some reduction in hospital deaths, but hospital admissions will go down quite a lot. Reported deaths will come later because it takes some time to report these deaths anyway. But that is quite interesting. This is from a group of actuaries who are working for SAGE, and it does tell its own story. So we'll wait and see what happens. Final points. More than 90% of people who die from COVID-19 have a pre-existing medical condition, and I've listed the sorts of things there for you. It is thought that about 12% of the total population of England have had COVID-19, and 10% of the population of Wales, 1 in 10 of us in Wales has had COVID. At least 25% of hospital doctors have had COVID. 50% of doctors working in ITU, intensive care units, have symptoms of post-traumatic stress disorder, which is, to me, a real worry. And we already have seen the deaths of quite senior medics. The second in command of the Royal College of Physicians of London has died from COVID, and other eminent people have died from COVID. The Emeritus Professor of Genetics here in Cardiff has died from COVID. And so we have, quite large numbers of active doctors have been quite badly affected. So we have a situation in which doctors and nurses, I have to add, have been really, really taken to bits by this. So what we need is a resuscitation program for the medical profession, as indicated on this slide. And what all of us need is represented on the next slide I'm going to show you. Happy holidays with our grandchildren or with our families. And that we will probably see next year. Whether or not we're going to have many happy holidays with our grandchildren this year, I think is still a moot point, but it might be possible. It might be possible. So there we are.
Well, thank you very much, Simon, for such an interesting talk. I assume you're happy to answer some questions.
Yes, indeed, indeed.
Okay. Perhaps I could just ask. You mentioned it in the talk. You were talking about the fact that people who have symptoms are actually
regular injections of dual
can pass the infection on from just before they get symptoms to just after. But then we've got a large number of people who are asymptomatic. When are they actually infectious to other people? Well,
that's an open question. There isn't really much evidence on this. I've kept an eye on the journals to see if this is going to be unwrapped, but there are some studies being set up to try and identify this. But clearly, quite a large number of people are completely asymptomatic when they have COVID. And it may be that they get more infectious if they've got other conditions, like if they've got asthma or if they're coughing a lot, etc. I mean, that's the theory. But it seems that people who have who have COVID without knowing it are not as infectious as those who are about to go down with it. And that's the best I can say at the moment. And certainly in the literature, there isn't a very clear statement about that question, David. Any other questions?
Yeah, Ian has got a question, but he said he can't raise his hand because he's a host.
I can't thank you, David. Thank you for your talk, Simon. For me, and being a former statistician, the actuarial tables were really interesting to see what effect the vaccination program has as it goes through those categories. I was wondering if similar sorts of numbers have been generated. Obviously, the figures you showed were against the whole population by age band. I was wondering whether you knew of similar tables that considered those that were vulnerable as opposed to the whole population.
I haven't seen that on the tables that I've looked at in the literature, but it's a possibility that may be the case. I mean, I think that's very likely to be the case, but I haven't seen the data on that, I'm afraid.
Nick Hawkins, did you have your hand up?
Nick?
Yes, Simon, thank you indeed. Well, one thing that's been intriguing me, and that is that obviously you have mentioned, and it's well known, that there are certain areas of the world, Australia, New Zealand, you mentioned, where by total isolation, they have got very few infections. But presumably the corollary of that is that they haven't got an immunity base either. So they presumably are going to be at greater risk for a long period of time until they can all be vaccinated.
Yeah, no, absolutely. And they will be rushing to get their population vaccinated as soon as they can get their hands on an approved vaccine. No, they are, particularly Australia and New Zealand, they're well on the way to doing that. And I think the situation in China is not that different now, that the Chinese are developing their own vaccines as well. And I think they're already rolling out vaccines in China. So the number of cases in China is relatively small in comparison to the population. So you're right, you know, they will be vaccinating their population as soon as they possibly can.
David?
Yeah, Nick?
Nick?
Hi, Simon, thank you very much for the talk. Just one interesting thought. I wonder if in future, when we come round to our annual flu jab, it will be a dual jab, one for the flu and one for the COVID.
I think that's very likely, because certainly COVID is not going to disappear. It's going to be around for quite some time, and one doesn't really know how long the piece of string is, quite honestly. But I think many people are anticipating that it will be around for 2 or 3 years, that sort of thing. But it will be obviously controlled much better by vaccination. The worry, I suppose, is going to be those countries where vaccination rates will not be as high as they ought to be, because you really need to get the majority of the at-risk population vaccinated in order to get herd immunity. I was just seeing today the figures for the likelihood of people in different countries in Europe getting vaccinated, and the figures for France were unbelievably low, something like only 23% or something of that sort, I think it was, and in the 20s anyway, prepared to be vaccinated. And Germany was only about 45% prepared to be vaccinated. Well, that's not enough to get herd immunity in the at-risk population.
Okay. I can't see any hands, but I'd like to ask another question, Simon. For something like HIV/AIDS, there was a lot of work done on the retroviral drugs.
Yeah.
And I think there is no immunisation for that, but no. It's being treated. For COVID, there doesn't seem to be any success with retroviral drugs at all. Are people looking at other ones, new ones? Because we hear a lot about vaccines, but not much about retroviral drugs.
Yes, well, retroviral antiretroviral drugs deal with retroviruses. I'm not a virologist, but the structure of the virus is rather different from the coronavirus. So I think antiviral drugs in general could well be used ultimately for COVID, but they will need to be developed specifically for the coronavirus type of virus. I mean, coronaviruses are a family of viruses, just like retroviruses are a family of viruses. And there are some drugs available even now that have some effect on the coronavirus group of viruses, but the overall impact of the drugs is relatively low. It's not. We don't have anything for coronaviruses that is as good as the antiretroviral drugs are for HIV. So that's rather a convoluted answer, but it's about having different types of antiviral drugs for the different types of viruses.
Thank you. I can't see any other hands up. So in that case, I'd like to thank you very much, Simon, for a very interesting talk. I'm sure people have learned an awful lot tonight. And I know, as usual, I think we've already presented you with a little token of our.
Yes, something arrived at the door which was presented to my wife when I was out for my walk this morning. So thank you very much for that. It's completely unexpected and not expected at all. But thank you very much indeed for that.
Okay, and thank you very much. I see some people are clapping, but they're all muted, so it's a muted clap. Okay, in that case, we'll move on the agenda. The next item was the minutes of the last meeting, which was the 16th of November, and any matters arising. Everybody should have seen these. They were sent out, and they have been on the website. Looking through them, I can't actually see any actions that are down there, or anything that aren't on the agenda. So if anybody has any items that they wish to raise from the minutes, please say so now. Otherwise, we'll pass them. Okay, right, we'll carry on. Treasurer's report, David Cargill.
Thank you. Accounts have been prepared for the 12 months to the end of December 2000. These are now subject to audit and the presentation to the AGM. But as we're all aware, 2000 was a very difficult year. However, with little or no activity, the association has managed to attract some income from grants and sponsorship towards the festival and the website, which is still very active. The Community Council have given a grant, and we had sponsorship from Redrow towards the festival and towards the website. And this has resulted in net income through the year of £3,030. Further sundry income gave us a grand total of £3,939. Expenditure incurred for printing programmes and raffle tickets totaled £12.59, and other items like insurance, film night licenses, Christmas trees, and some miscellaneous expenditure totaled £2,249. So the overall result was a surplus of £1,690 in the year, which I think we would have been very happy with if we'd done a festival. This has resulted in an improvement in the bank balance over the previous year and strengthened the balance sheet for 2021. Our festival charity, 10 of us, received 2,573 from donations from the schools and the WI, and this was topped up at Christmas by a further £1,000 they collected in buckets around the Santa sleigh. So with all that, we hope that 2021 will be a better year and we should be well prepared for it.
Thank you. Has anybody got any questions for David? Okay, we'll then move on to Festival 2021. this is something we've been looking at obviously for some time, and it's really a difficult thing to work on when we don't know what the regulations are going to be, what restrictions we're going to have. But I think one thing that was very clear, that even with everybody above 70 and vulnerable groups having their first injection by the middle of February, it's going to be probably getting on towards mid-May before even that group have their second vaccination. Therefore, we all felt it's very unlikely that many restrictions are going to come off by May, especially allowing groups of people to meet together. And based on that, we made a decision that we would not hold a full festival in May. What we would do was cut back the timing from between May the 1st and May the 9th and have a mini festival. And during this time we would have basically online events and competitions, a bit like we did last September. This time, of course, we have a lot more time to plan it, because last time we did this very quickly. So we're going to have a small festival from the 1st to the 9th of May, and then we've decided we will have a larger festival, hopefully, between the 11th and 25th of September. And it's going to be put back until September. We may end up having some smaller number of events, but an actual bigger events, or a smaller number of bigger events. But of course all of this depends on regulations at the time and what we're allowed to do, and we're hopeful that by September we will be able to go ahead with some of the larger events. We also agreed that we were going to keep Tenebris as our charity until the end of the September festival, so at least they would have had a full festival, and then our next charity, who we haven't actually been able to speak to for some time, who are Headway, hopefully would take over at the end of September and would then be in place for Christmas and the next festival in May. There will be some events in May. We've already been speaking to Tenebris, and we're talking about having another Tenebris quiz, which will be a quiz online on Zoom. There is a possibility, depending on the situation and what people are allowed to do, that we could have an open garden event in May. But this all depends, as I said, on the regulations. And some of the events that we held in September, the competitions, the treasure trail and things we'll look at. We'll also look at possible events like having a cookery demonstration or some sort of book reading or that sort of event. So these are all now being looked at. So basically the festival will be split into two bits this year, 1 week in May for an online type event, and 2 weeks in September where hopefully we will be able to carry on more in the style we're used to, though there may well still be restrictions on numbers, and if there are, things like the concert in the park may not be able to go ahead. We also decided that because of the timescales we wouldn't be producing a big glossy programme this year, and what we will do, we'll use the festival website a lot more again, and possibly A4 flyers closer to the time, and that would actually make it a lot easier for us to do things later on, because I'm assured we can get artists and things quite quickly these days, because they're just not being booked. So we'll have a lot more time now to do things. So that is the plan for the festival this year. I don't know if anybody has any questions on that. Okay, in that case we'll move on. Ian, could you talk about our Zoom license, please?
I can indeed. So the RMA has a Zoom license. We use it for our own events, but we've also made the decision to offer this out as a facility for other groups across the community of Radda and Morganstown. It's part of our charity objective to make sure that we are making Radda and Morganstown a good place to live and work. This has been already used by Trevorgan WI. I know the History Society are booked in for some meetings in the next few weeks, and a couple of other groups have already contacted us. So if you have a community group that is not meeting at the moment because you can't and you're not quite sure how to, the RMA have worked out how we do it, and we've got a license that is available for you to be able to utilise to allow your group to be able to meet whilst we can't do things in a physical way. we're offering this as a service to those organisations that serve Radda and Morganstown. There's a dedicated email address. You just email zoom@radda.org.uk with the details of what you'd like to do, or if you'd like someone to have a chat with you about the art of the possible, you'll probably get through to myself or David, and we'll come back to you to have a chat about how you can use that facility. But we really are looking to try and help groups that would normally meet to be able to do so in an online way. So there's some details on the radda.org.uk website, or email zoom@radda.org.uk, and someone will get back to you.
Okay, thank you, Ian. In that case, we'll move on to planning and the Cardiff LDB. Nick, are you?
Thank you, David. Yeah, slightly technical. I'll deal with this brief as I can. People will be aware that we are currently working through something called the Cardiff Local Development Plan, which was adopted back in 2016, and that's designed to run until 2026. Cardiff are now reviewing and revising that plan, and the new plan will run from 2021 to 2036. The RMA, along with other people, did have concerns about the problems with building the original plan, and we joined with the Community Council in working with other community councils locally, trying to make a difference. And you may have heard of something called the Northwest Cardiff Group. We are now named under the new process, which is just starting up, as a general consultation body in the new process. We're going to continue to work with and assist the Northwest Cardiff Group as best we can in trying to add value to the LDP debate, and we'll obviously also work with the Community Council. If anybody wants further information about that or can help us with that process, then please get in touch. The first responses, incidentally, to the initial review are due by the 4th of February. We won't be contributing, I don't think, to that, but then there's quite a long period followed by consultation. I've got various dates. There's about an 18-month period after that. So basically, we're just simply telling you that we are going to be involved with this. We will be joining the Northwest Cardiff Group. We will be making submissions on your behalf on the basis of the work essentially that they're doing. If we can assist with them, we can. But if anybody knows wishes to be involved with that process, then please let me know. You're on mute, David.
Has anybody got any other business or anything they wish to raise?
Is this where you'd like me to talk about our next session, David?
Well, that was going to be the last item, yes. The date of the next meeting is the 1st of March, and Ian is going to tell us about the speaker.
So our next session is by another Simon. This time we have Simon Bradwick coming to talk to us about the living tap. And Simon is a part of a group who have, for the past few years, been working with some storytelling experts to try and tell the story of the lives around the River Taff and the life of the River Taff as it flows from Brecon down past us, through us even, into Cardiff and out to the sea. And we're really keen to be able to work with Simon as the RMA to make sure that Radda's part and Morganstown's part of the story of the Taff gets told. And whether that's something historic that we know has gone on around here, or simply the way that the Taff is used within our lives today. And with lockdown, I think the Taff has played a big part of many of our lives as somewhere we can escape to, walk up and down and so forth. So Simon is coming to tell some of the stories that he knows already, but also to help encourage us to tell more of the story of the Taff.
Thank you, Ian. So there will be a note coming round about that with, again, a link to register for that meeting. Okay, well, thank you all very much for joining us tonight. And thank you again, Simon Smail, this time, for the excellent talk we had, and I look forward to seeing you all again on the 1st of March. Thank you.